Go ahead and call this. Okay, thanks. I'm going to go ahead and call this meeting to order. This is the Incarceration Prevention and Reduction Task Force Behavioral Health Subcommittee, and we're meeting here on October 19th, 2021, and we're meeting virtually. Before we begin, I'd like to acknowledge that we're gathered here today on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. All right, I'm going to go to our second item here today, and this is a presentation by Under Sheriff Doug Chadwick.
Well, good morning. I think many of you were at the combined Behavioral Health and the Legal and Justice Committee, and I was asked to provide an overview of the essentially having embedded behavioral health clinicians right along with law enforcement. So as we've been discussing over the last year and a half, other options to just sending law enforcement to these type of calls, whether it's an unarmed response. I mean, we've talked about having paramedics, EMTs partner with behavioral health specialists. And then one of the other co-responder models we've discussed is having a mental health clinician riding with law enforcement in the field. And again, for the sheriff's office in the rural sections of Whatcom County, I think that's a good model, and it's already being done in Skagit County, the impact program. And I can talk about that a little more shortly. I just got off the phone with their chief criminal deputy and just kind of got a status update of where they're at with that program and some of the challenges that they've had and some of the things that they've got in the works as well. So obviously the idea is to have a behavioral health specialist in the car with the deputy. And again, the sheriff's office has 2 behavioral health deputies right now. So their primary focus is to respond to those. If they hear something over the radio that is likely to be somebody in some sort of behavioral health crisis, they would take that call and respond, or they'd respond in conjunction with another deputy. And then they also follow up on some of those people in the community that we respond to on a more regular basis. And those are some of the people that are involved in the GRACE program, people that we refer to lead. And that's really the role of our behavioral health deputies is to take point on those type of calls, but also to know what resources are available in the community and work with GRACE and LEAD to get people the help that they need. And like I said, we started with one, we added another just because of staffing and budget cuts. We had to cut back last year, and we're back at the 2 behavioral health deputies now. So Deputy Geraldine Clicks and Deputy Lonnie Bauman are uniquely qualified. They are great deputies. They have the right personality to do that type of work. Definitely very caring, compassionate folks that are able to talk to people. Geraldine has a background as an EMT firefighter, so that's obviously helpful as well. So at any rate, we've talked, and I know Ann Deacon supported trying to find funding for that, and I believe she did find some funding. So if there's any way via the health department or Compass, I don't know who's going to take point on that. If they can hire somebody and have them ride with one of our deputies out in the field, I think that not only increases the safety of the behavioral health clinicians, but also provides a more immediate response to somebody in mental health crisis with somebody that has that level of expertise. Obviously, our deputies are trained in de-escalation and identifying people on behavioral health crisis. But once they triage that call and make their assessment, they generally would be reaching out to programs such as MCOT if they need more of a immediate response. If it meets the ITA, Involuntary Treatment Act criteria, they could take that person involuntary and take them to the hospital. But as we've discussed, some of these legislative changes have really reduced the number of times that those criteria are met, and we're actually taking people into protective custody and taking them down to St. Joseph's to try and put them in contact with somebody that can help them. So that's really the program. And as I alluded to, Skagit County Sheriff's Office started the impact program down there about 2 years ago. And like I said, I talked to them earlier today, just see where they're at with that program. They currently have 4 deputies are specifically designated. So similar to our mental health deputies, that is their primary responsibility. And they have 7 mental health professionals down there. Some of them are just mental health. Some of them do both substance use disorder and mental health, but they ride along with the deputies. But they're also one of the positions. So 4 of them will ride with the 4 Skagit County deputies. They have one that they plan on putting in an office out in the east part of Skagit County in Concrete, and that's where their office would be. That clinician would have their own vehicle, so they could either jump in with the deputies or they could actually respond to the scene in their own vehicle if it gets in the remote portions of Skagit County. And then they're going to have 2 more behavioral health clinicians, and they will be working with the small cities, Cedar-Woolley, Mount Vernon, Burlington, Anacortes. So that's their plan down there. It's a fairly robust program. Some of the challenges they said they've had is we've seen here in Whatcom County as well, is just one, getting enough capacity, getting enough staff to handle the need. And the other is retaining them. They seem to have some significant turnover. And I think you're seeing that everywhere. So one of the things that is they're looking down there is, rather than, contracting with somebody else, having them actually hired as county employees and trying to pay them a little higher wage so that they stay there and they don't continue to have to train people on a regular basis. So again, that's essentially the program down there. It's putting behavioral health clinicians in the car with the deputies. And again, when they get to the scene, if it's more appropriate for that behavioral health specialist to address the situation, they can step forward, the deputy can step back, but they're still there. They're still there on scene. Again, working within the parameters of the new legislation. If there's no crime or there's no immediate threat, how does that work with when they're together like that? And they're not able to, if the deputy were to leave, they would essentially leave that behavioral health provider there by themselves. So is it better to have them riding with the deputies? I mean, there's certainly some benefits to that as far as a rapid response, but it also requires both to be on scene the entire time unless that behavioral health clinician has their own vehicle. So that's essentially the program that's working in Skagit County. The sheriff's office would love to have some people, whether it's a contracted provider or the county can hire their own to place in the vehicles with the deputies and provide that level of security. But I'm happy to answer any questions if you have any.
Chief Tank.
Yeah, Doug, thanks for that update. I mean, that's really helpful. Were you able to ascertain down in Skagit if, when the provider rides with the deputy, what happens in between those calls? So does the deputy drop the provider off at a certain location back to the office, or do they continue to ride with that deputy? And does that deputy that's with the provider, do they answer other type of calls? Because as you know, as in law enforcement, that we never know what type of call is going to come out, and that specific time. So what happens in between, not only for the efficiency of the program, but also for the safety of the provider?
Yeah, my understanding is that they ride with them the entire shift, especially for the deputies out in the county. It's just not, again, from an efficiency standpoint, to drive all the way back into Bellingham or to drop somebody off isn't going to work. And that's one of the reasons for that that remote position out in Concrete, they're looking at having them with their own vehicle so they can either ride with that deputy or they can respond in their own vehicle. Because as you noted, the deputy may have to, if there's an emergent call and that deputy's in that area, they're going to respond. It's similar to when we've had civilian ride-alongs in our cars. We still do that program when we're not in COVID protocols, where citizens come out, ride and see what the deputies do on a daily basis, which I think is very beneficial for community members to see that. But also if they're responding to a shooting or something that has a high potential for a high risk, I've had to drop civilian ride-alongs off and at a store or something like that and tell them I will come back and get you, or I'll send somebody else to come back and get you, but certainly don't want to take them there. And that may be the case with a behavioral health clinician. But I envision that if they're in the car with them, they'll be there for the day. And it may be, I would think maybe they come out and ride a couple days a week with our deputies, and then they have their own vehicles and can respond as well. Would be ideal, but that comes with an extra cost when you're providing vehicles for staff.
Mike Parker, then Perry.
Doug, thanks for the presentation. And, I'm familiar with the programs, but I get a lot more out of it when I actually hear it from the words from somebody who would implement it. So I really appreciate that this morning. I had, you kind of touched on this a little bit with ITAs, but, I know that your deputies every day are out there serving people with behavioral health challenges, but you have some specialized calls that you all attend to. Specifically, you mentioned ITAs. I know sometimes you guys are involved in welfare checks. There's a variety of ones that are known. How would you say, or how would you tell us that the impact program, if we did something similar here, how might that change how you respond, or your ability to respond, or how do you envision that kind of shifting if you have that asset in your department? What could change for you with some of those specialized calls?
We already have we have half of the asset already in those two behavioral health deputies, and that's what they're doing. They're when they hear it over the air, they see it on the screen, they will self-dispatch themselves to those calls that they think will have a mental health or a substance use disorder component. And again, I envision if there is a embedded clinician with them, obviously that provides a very rapid response for those services, as opposed to right now, our behavioral health deputies would go out, and once they're able to stabilize the scene and realize, well, I need to get MCOT or something, there's obviously a delayed response. I know MCOT is working to increase that response, but likely they're going to have to respond from Bellingham, and depending on where they are out in the county, that's going to be a delay. So does the deputy stay on scene until they show up? Does the deputy just make a referral? It really depends on the acuity of the situation. Is this somebody that needs help right now, or is this somebody that you can refer and have somebody follow up the next day? So that's how I see it. But I think having them in the cars will provide that immediate service, as opposed to 30 minutes, an hour, maybe longer if we're referring that to another contract provider.
Perry Mowry.
Thanks, Doug, for the information. I was just curious, is there, if the call is such that it's deemed to be a safe environment, and the mental health professional is behavioral professional is working with the individual, is there anything that the deputy can do at that point in time? I mean, is there paperwork, or is there anything that they can take off their list of stuff while they are waiting for that behavioral health specialist to wrap that situation up, or that's not really how it works?
If it was safe to do so, obviously they have computers in the car, and we can access all our reports are submitted electronically now. So the deputies actually write their reports in the car, and they may have a backlog. Just if they're going to one call after another, they're not going to be able to write all their reports. So they could start on that and actually submit that from the field. And that's what they do now. They don't come into Bellingham and submit those. That's when we transitioned to that Spillman records management system. I believe in 2014, that changed.
Thanks.
Arlene Feld. Arlene, do you have a question?
Hear you. Yeah, my question is about DV calls, domestic violence. It's such a gray area, and so many different kinds of things can be happening in a domestic violence call. Is the counseling person always on those calls, or is a decision made before they go out?
Well, all our deputies respond, if it's a verbal domestic or a physical domestic, all the deputies are trained to handle that. Actually, one of the behavioral health deputies used to be one of our domestic violence specialists. So he obviously has some of that background when it comes to interview, but yeah, we don't have any specific provider that rides with the deputies on those for domestic violence purposes. You're thinking maybe somebody from DV SAS or organizations such as that?
No, it would be, it doesn't need to be a specialist. It can be just somebody who understands, psychologically what's going on in family conflict.
Sure. And we have, when we respond to those type of calls, we have a list that we leave with the victim. And it has a list of resources, and depending on the situation, we'll actually make that call and put them directly in contact with
Okay.
somebody that has that expertise.
So I think your answer is no. They don't go out on the calls.
I guess I didn't completely understand your question. We don't have DV consultants that regularly come out in the field. We do provide resources, and we can call.
I understand.
We can take people to those resources if necessary.
Okay.
Dean?
You'll note that farther down on your agenda is a discussion about the alternative response teams. And Perry has asked me to be here. In case you don't all know, I'm helping fill in for Ann Deacon while they find her replacement. But I'm just wondering if it might make sense for the continuity of the conversation to bring that item up immediately following this one, just so that, because there is a substantial relationship between the two.
Yeah, I think that's a good call. Let's reorder that one and make that the next item for discussion. Good call.
And Dean, just to clarify, I know before Ann left, she said there was funding for behavioral health clinicians to actually put them in the cars with deputies. Is that something that's in the works, or is that not been posted?
I think Perry's probably the one that may have an answer to that. I haven't heard of that, but I haven't studied the budget closely since I've started. So,
I don't know, Doug, but I will find out, and I'll communicate that back, and obviously with you and the rest of the subcommittee here.
Thank you.
Okay.
Arlene hit one kind of special population of focus that this group looks at a lot, which is domestic violence situations and survivors. I'm also curious too, our committee has looked at upstream work. We're pretty interested in youth and how things happen. Could you touch briefly on how impact program or our version of an impact program here in Whatcom County with your deputies, how might that affect how we respond to calls involving juveniles? Is there specialized training or anything?
Yeah, I would agree that that's, and I know I've, in some of the other committees that I sit on, I brought that up, that I really think there is a lack of resources, whether it's behavioral health, substance use disorder, or even sheltering options. And I know Northwest Youth Services has done a lot of work to try and improve that. So certainly part of the behavioral health deputy program is knowing what resources are available. And I'd love to see additional resources that really focus on that group, the 14 to 19-year-olds would be ideal, because I think a lot of times the circumstances that lead to that and maybe some of the services that they need are different.
Chris, go ahead.
Hey, Doug, I think that there's a lot of potential maybe for us to work together on that. I think the districts, in fact, all 6 or 7 districts in the county have made quite a bit of progress in the last couple of years. I know Linden just hired a mental health coordinator. I'm in that position for Bellingham, and we've just hired 2 mental health specialists. All myself and the other 2 are all licensed therapists. And we do have a family engagement department, which is really helpful with kids who are unaccompanied youth or homeless. So whether it's behavioral health or whether it's homelessness, if there's something I can do to help, and I know I've worked with, Jamie a little bit when he was with you guys, and now he's with Compass. But if there's things that we can do to liaison that way, I'm more than happy to do that. We do have a kind of a parallel intake process with Compass and CMAR, so that even if they may have no openings for the general community, we have a parallel intake. We can sometimes get student services even when those are closed. So I'll put my contact in the chat, or I guess we don't have that here, but anyhow, I'll connect with you some way. I'd love to talk about how we can do that.
Okay, that's great. And I will verify if those behavioral health deputies have that. I mean, that would be great to get that information for all the school districts, and depending on what area of the county they're in, that would be a great resource if they're not all already aware of it.
Dean?
And just for my edification, Chris, I'm sorry, are you going to sit with the Bellingham School District? Is that where you are, or City of Bellingham? I didn't understand.
Yeah, I apologize. I should have introduced myself better. So I work with Bellingham Schools, and so this is a new department, new position the last year and a half as a mental health coordinator across the district. We have all our school counselors in addition to that, but so there's myself and 2 mental health specialists that our goal is to support those 23 schools and about 11,000 kids with using what's already available in the community first. So we're not duplicating services, but being able to fill those gaps for our kiddos with either private insurance, no insurance, things like that, crisis situations.
Yeah, I thought so. I've heard good things about your work. Thanks.
I want to just add to the conversation real quick here before we transition over to ART to provide the group a couple updates here. One is that at Northwest Youth Services was mentioned previously in this conversation. They are developing I believe it's a 12-person repurposing a home up on Toledo Hill for 13 to 17-year-olds. So there's a shelter option there that'll free up the pad on State Street for their young adult clients. I believe that's 17 to 24, if I've got that right. So it's an additive capacity. And then just down the street, there's in development. It's going to be a few years out, probably 3 years out. There's a Bellingham Home Fund funded project for seniors that will have a childcare facility within the building. Brian Thane, does Samish Commons have childcare within that facility?
So we have early Head Start at 2 facilities. One at Heather Commons off East Bakerview, and one at the Birches, which is in the unincorporated neighborhood of, I believe, Alderwood. And we're negotiating with a potential early learning provider for one of the commercial spaces at Samish Commons, the former Aloha Motel site.
Okay. Thanks. Before I go to Mike Parker, the reason we bring this stuff up here in this committee is because we know that adverse childhood experiences are contributing factors to potential later criminogenic behavior. And the more that we can reduce those, kids are not welcome in our jail when they turn 18. They're welcome at the community college, and they're welcome in jobs. Mike Parker, go ahead.
Thanks, Dan. This is kind of a straddle question, so it might be a bit for Doug and it might be a bit for Dean or Perry, who are going to talk to us about alternative response. This question is really about do Doug and Dean and Perry, folks that are kind of really more experts in this area of expanding behavioral health resources within our law enforcement. Do we think that this in some way might be the special sauce that we need to get our crisis solutions center to be working the way that we want to? I'm curious if we see capacity here in enhancing our behavioral health clinical response. Will that is that kind of what maybe is missing from optimum usage of the great facility that we have right now? Or do you all see something else that we might need to do? I guess I have some hope. I think as we increase those behavioral health resources, I'm hoping that really smooths out any kinks that we may have with being able to drop off folks. But I'm just curious what y'all think.
I'll probably let Dean or Perry take that one as far as the Crisis Stabilization Center.
I was waiting for Perry to take his mute off because I think he should start, but I'll step in when you want me to.
Absolutely. Well, first, I think that we have really made some great progress in regards to the Crisis Stabilization Center at this point on both sides actually reaching capacity, predominantly filling beds. I don't know that I have it exact, but as we've met we meet monthly with a Crisis Stabilization Center Advisory Committee, and we're at or above 85% of filled beds at this point. But we continue to work on the streamlining the delivery of individuals from first responders in general. We've certainly made some inroads in terms of both of the providers viewing law enforcement as being priority. They need to get in, they need to get out, those kinds of things. So we've done quite a bit of communication there, but there's more work to be done, in that regard, because there can be challenges, obviously, if an individual is combative or becomes combative, afterwards, after they're dropped off, those sorts of things. The other thing that is also occurring is there are proviso dollars that are available coming in 2022 that I'm working with the behavioral health ASO, the BHASO at this point in time, that are specifically oriented towards the completion of ITA and of the ability of the facility to have involuntary certification with the state for that 12-hour police hold. So that's in the works. It's fairly sophisticated in terms of what we need to do, but it's a primary target and goal of what's going on. So I think that the kind of thing that that Doug is talking about is just imperative in terms of that open communication and continued work with law enforcement as well as other first responders in order to streamline this process, because it's honestly fairly sophisticated. What a lot of times isn't understood is that when we established the Crisis Stabilization Center, we also increased the level of care in both of the facilities, so it becomes more sophisticated with medications, and for example, it's not a social detox anymore. It's a medically monitored detox, and so admissions becomes more of a challenge because there's a higher risk of liability if an individual has a primary issue or has meds on board, or something of that nature is one example. So that is some of the pieces that we're working with, and I'll commit to continuing to update the behavioral subcommittee just in regards to our work on the Crisis Stabilization Center Advisory Committee.
Thanks, Perry. Before we begin the discussion on AR, Dean, did you have something? Sorry.
Well, this maybe is a transition to the next discussion, but I think what Ann would say is that the Crisis Stabilization Center is one piece of an overall system, and all those pieces need to really work well together, and we need to look at where the gaps are in that overall system. It's not itself sort of a solution to all of our problems by any means.
Fair enough. I just wanted to point out Bellingham PD has one behavioral health officer, and that officer will be transitioning back to patrol pretty soon here. I believe that's in November. We budgeted, city council passed a budget that had 3 additional spots for BHOs. There wasn't a single applicant for those positions. So we're going to go from 1 to 0. It's really concerning to not have those resources within our police system. And I'm just a little bit at a loss here as to try to figure out what to do other than ART. I'm hopeful for that, but I'm at a loss. Go ahead, Perry.
Yeah, just to tag on to that, Dan, because I really appreciate that. that I've been in communication, quite a bit of communication with John Dukes relative to MCOT. And he had just absolutely expressed a concern because the BPD officer, Zach Surratt, has really been crucial in communication and a number of components between MCOT and BPD. And so he had some real concerns about that vacancy and what I should use the word impact, what effect that will have, in regards to MCOT and their ability to provide services. So I appreciate your thoughts and concerns there.
I rode along with Officer Surratt and Laura Woods, who's the Grace case manager, what seems like a different lifetime ago, basically before COVID. And a lot of the work that was being done by both of them was keeping people housed and keeping people away from the system. And I'm just concerned that some of the folks that we saw, it would be challenging for them to survive a night or two out on the streets. I'm just really concerned about. Some of these folks are senior citizens, some have disabilities, and just really concerned that resource is going away. Go ahead, Chief Tank.
So, it just occurred to me that in many areas, in many counties, they have like a multi-jurisdictional drug team and things like that, And as we think about our response for law enforcement and behavioral health representatives, I think in the future we might want to start thinking about perhaps, is there a way, of course this would require a lot of communication and agreements between multiple agencies and cities, but like those multi-jurisdictional drug teams, at one point we might think about considering like a multi-jurisdictional behavioral health team for law enforcement agencies to share these different resources. It's just a thought, just going forward. But for example, in Blaine, we have a staff of 14 officers. The two largest agencies is the Sheriff's Department and Bellingham, but there's a need for this in other parts of the county as well that is not unincorporated, or it's not the city of Bellingham. So it's just a thought.
Sheriff, Chief Dahl, his intention, he said, was to have 6 behavioral health officers. That was really what he was looking towards in the future.
Yeah, that for the short term, or the near term rather, that is not happening. Go ahead, Mike Hilly.
Yeah, thanks. Chief Tanksley makes some really good points. As we talk about the alternative response teams in the next conversation, we have to think about how to cover 13 different fire department districts, agencies across the county. And I could see some resource sharing with this too, with finding a mental health person or somebody with SUD that could share that and be somewhat flexible or mobile around the county that could support both these teams, adding capacity for the low acuity calls, but having somebody there for these crisis calls that need that immediate attention. I think there's a lot of merit in that idea.
Anyone want to respond to that?
I think to a certain extent, that's what SCAD is doing. They have 7 mental health providers. 4 of them are with the sheriff's office, and then the other 3 are spread around the county to small jurisdictions. And then one's actually going to have an office with their own vehicle out east in Concrete. So a little bit of a hybrid of that concept, but I think they're trying to share the resources. So they've got a good number of mental health providers that are going to work directly with law enforcement, which I think is a good thing.
Dean, go ahead.
Well, I'm going to take this as an opportunity to make the transition to the alternative response, because I think the underlying issues that we were just talking about really are what are also facing us in terms of the challenge of trying to figure out what's the best next step. I take to heart the chief's comment about the potential value of cross-jurisdictional, cross-functional collaboration among different parts of government and the human services arena. Grace really was an example of that kind of collaboration being put in place, and it has been both highly successful and very challenging at the same time. Let me just give you an example. We employ, somebody mentioned Laura, Andrea works in conjunction with the fire department paramedics and paired up with their community paramedic. Those folks are employees of CMAR functioning in a role that puts them together with both fire and police in the city. And one of the challenges that we've been facing as we've been grappling with this question of how to put an alternative response team in place is sort of command and control. Who employs the people? If they're employed by different organizations, how do we collaborate operationally and logistically to make sure that they work smoothly together? I think that's been one of the challenges that I've heard about with the impact program in Skagit is just, how do you coordinate between the law enforcement and Compass, particularly when Compass has such a hard time keeping positions filled. And of course, that's a challenge, as you mentioned, Doug, for us in all of these current efforts to get underway. And so, back in January, I want to just give a little bit of background history on how we've been moving forward on this alternative response conversation. Back in January, really even before, but I think really convened late December, early January, and convened a group of folks from the various stakeholders to start talking through how do we now create a legitimate response to what the community has been demanding in the way of an alternate response to law enforcement. And I think, obviously what happened was a fair amount of analysis of information from dispatch, from Whatcom and Prospect and other information to try to ferret out, what's the right kind of intervention to drop into a current system as an added piece rather than to simply create something all brand new in isolation from the other things that we're doing. And that was going pretty well. I think Anne felt that she had developed some consensus, at least, around moving forward. And then, of course, House Bill 1310 happened. And I think to some extent, the Blake decision impacted where we are. And so as a result, now there are sort of conversations about different models, and we've sort of lost some of the consensus that we had back in May or June. Anne had put forward sort of two models that were presented to the executive and the mayor. But in conversation with them and the group of folks from the city and the county, I think we agreed we need to step back, look at some of the data we were looking at back in the spring, now that we've had those two events occur, and understand in numerical terms how things have changed. Not to spend a lot of time getting paralyzed by our analysis, but just to say, look, what are different about the kinds of calls and the routing of those calls and the ultimate response of those calls since those things have happened. The mayor and the executive agreed that was a good idea. And they've designated in each case who stakeholders are that ought to be brought together sort of at two levels. One, a kind of an executive group that can really work on pulling data together fairly quickly. And then a larger body to whom that would be presented along with some recommendations for, which things to do first, second, third, given resources. I think, Doug, the elements of the impact program that you referred to are certainly, they merit examination as a part of that process as well. I noted from the material in the slides that, and as you alluded to, some elements of that is what Grace is now doing, and we just need to figure in how would those mesh if we were to do that kind of program as you suggest. One thing I would mention is that, as some of you may know, dispatch folks and the MCOT have been talking about how can they at least work a bit better together to figure out how to dispatch calls and when to call MCOT versus law enforcement or fire, handing it off to Prospect. And as a result, they've got something in the works that I think makes a lot of sense as sort of a trial activity that also will yield some additional information to us. And that is that the MCOT team, Mobile Crisis Outreach Team, is proposing to place its person who takes the calls for MCOT actually physically in dispatch at Whatcom, and to work together with dispatch there to try to sort out what are the kinds of calls that might be routed and routed more quickly perhaps to MCOT versus routed the normal route through either law enforcement or to prospect and fire. And I met with them yesterday with Allison Everbeck and John to hear what they're doing. And I've encouraged them to keep moving with that as well. Right now, the challenge we've got is, as I mentioned earlier, the whole issue of jurisdiction and who employs whom in any kind of a alternative response team. There are proposals on the table to have the behavioral health folks employed by fire in Bellingham. There are proposals to have those persons employed by a social service organization such as CMAR, including under Grace's supervision. There are issues that I've heard about whether it's even the best use of fire to respond to these kinds of calls, if a different kind of team could be dispatched in some way. But then, of course, those raise issues of safety, as you've alluded to, Doug, in your discussion. I think others have as well. So that's the mix of issues and think underlying common concerns that I'm hoping to bring people together and discuss fairly shortly within the next 2 or 3 weeks and see what we can arrive at in terms of a next steps going forward to get some things in place. And I think, Doug, you're certainly going to be a part of that discussion. Mike, there are several folks that the city's identified and also folks within the county and human services and other areas. So that's where we stand. And I think I'm happy to take questions about that process and where we are.
Questions from the group?
And I think this was kind of implicit, but when you speak about ART and kind of expansion or creating new, you're really talking about expanding MCOT, expanding, changing, and adding to that as a model for an ART team. Is that correct? Am I hearing that correctly?
No, I'm not. That's a possibility, but it's, you know,
Okay.
When Ann developed her recommendation, she had sort of 2 things that she displayed ultimately to present to the mayor and the executive. And those were, you know, expand MCOT, increase its capacity, or have a team that is some kind of paired between community paramedic or EMT, fire, and a human services employee to work as teams. And she had come down on the side of the latter. I think primarily because she was concerned about the issues around capacity and the ability to recruit the workforce, which really cuts across all areas. But I think they're really 2 parts of a continuum rather than competing proposals. There are things that we can do with MCOT to have it function better. And this notion of co-locating the person who takes the MCOT calls at dispatch, I think, is one good example of something that's a good experiment. And then the question of, do we add MCOT capacity and have those folks be co-responders with both either fire or police? Those are things that are under consideration.
I want to chime in here real quick. So the ART was conceived in this committee in March of 2020. And I brought it forward in my committee on council, which is the Public Health, Safety, and Justice Committee, and got a 3-0 vote to bring it to the full council. That would have been late last year. I don't remember the date. Council approved it, directed the administration to come up with a budget item for it, to pay for it. Administration was in full agreement. There was complete head nods. There was not a single no or resistance, but this is taking way too long. Law enforcement has been the catch-all for behavioral health for years. We just learned yesterday that this Washington State Patrol has 10 troopers assigned to this region. Now it's lost 5 of them. we are facing a 40% of our workforce of the city is eligible for retirement in the next 5 years. We're facing reductions in law enforcement. We just talked about the BHO program. That's a big zero at this point. We have to come up with, and we need to be more agile when it comes to behavioral health responses, and we need to create programs. These things take forever to create, and I get it. And I'm not blaming anyone here. That's not the point. The point is that we need to work a little bit faster here on getting a response, whether it's an expanded MCOT or an alternate response team that's housed wherever. To me, at this point, we need to move quicker. When the jail vote failed, we came up with electronic home monitoring, and we did it pretty quickly because we had to. And I feel like we're in a very similar situation now with the level of behavioral health responses that we need to get to help alleviate the person's situation, the family situation. And I feel the sense of urgency is more acute now. Mike Hilly, go ahead.
Yeah, thanks, Councilmember Hammer. And I was just going to echo the same thing. I'm getting the same sort of sense of urgency from our county fire chiefs. I've received a couple of letters, urging us to get something going. And this is more a response to the calls that have been diverted over to EMS in the last couple of 3 or 4 months, because it's putting a big load on these very small fire departments that have part paid or volunteer people. And so some of the community discussion is how could we share this resource in certain sectors of the county to get those calls knocked out that leaves those other crews in service for the emergency work, as it were. So I just want to relay that coming from the Fire Chiefs Association is wanting to get something up. And I don't know if we'll meet it, but they were hoping to get something by June, July next year operational.
Go ahead, Dean.
Well, so Dan, I certainly understand your sense of urgency about this. I don't disagree in any way. And that's the marching orders that I'm acting under when I'm trying to now move this process forward. Obviously, in addition to the transition as Ann has left, we're trying to figure out how to keep things moving. But the other big challenge that's going to be, the critical point is our workforce issues. And we can come up with a program and say, okay, well, now we're going to post jobs and start them tomorrow. And then we're going to be right up against the workforce problems that we have across the board in behavioral health, apparently now in law enforcement and fire, and other areas crucial to community well-being. So, I know my marching orders. I agree with you though, that urgency is the call of the day.
Yeah, and Dean, I don't want you to take it the wrong way. I'm just really frustrated. I get these emails from family members they're saying, we're at our wit's end. We've tried everything. We don't know what to do. And I get the complexities of what you're facing, of not robbing Peter to pay Paul. I don't want to rob Grace case managers but we can't prevent them from applying for jobs with ART. I think that, the more I think about this, and we've lost Ann Deacon. I mean, she's retired. We haven't lost her, but but the confluence of all these issues of, no more Ann, all the House bills, the workforce issues, I get it. And so what I'm saying is, Dean, whatever I can do or whatever we can do as a group to help you and Perry and whoever else is working on these issues, I'm here. I'm all ears, and I will do, whatever it takes on the council side of things. Pardon me. I just really feel like we're in this very new place, and I want to make sure that the families get served.
Yeah.
And Dean, I don't know if you want to respond to that before we go to Mike.
No, I hear you. I'm fine.
Okay, go ahead, Mike Parker.
Thanks for calling on me. So, I know this group, especially in this committee, we talked a lot about, we took Deputy Executive Schroeder's charge to heart, right? What would you recommend us do with Whatcom County's ARPA funds? And one of the things that we said is address the behavioral health workforce. I'm curious from Michael Smith or Chris Cochran or Dean, we've got lots of specialists here. We've got clinically licensed folks. I'm one myself. Is there further direction from this committee? So for example, I mean, we said that this is a high priority for funds, but do we need to like convene focus groups? Do we need to like, is it just money? Like what's going to be instructive to move the needle to have people apply for those positions? And I'm just curious because there's a lot of wisdom in here from both sides of this, right? Both from our law enforcement folks who've been doing this for years and having behavioral health deputies with some success until they left. And also we've got some behavioral health folks. And I'm just really curious if there's information or ideas that people have, and should we as a committee be more instructive than just say make this a priority and devote funding for it? Do we need to be more toothsome in our recommendations to move the needle? Because I'm seeing across the board we've got community will, we have buy-in from law enforcement, behavioral health, this is a good direction. And yet, why are we still stymied and why are we still stuck? So I just want to throw that up. And I'm really curious from behavioral health folks that maybe haven't had a chance to chime in yet, just what their thoughts are.
Okay, a bunch of hands went up at once. I don't know, Dean, your hand was still up. Are you wanting to respond or should I go to Perry and then Michael?
Go to Perry and Arlene, and then I'll chime in after that.
Okay, go ahead, Perry, and then Michael.
Yeah, just super quick. We touched base a little bit on this yesterday, but there is a state committee that is, I believe it's part of the Healthcare Authority, if not, but that is specifically making recommendations relative to workforce and being able to have an impact on that, because we know this is a statewide issue. It may be a bit more accentuated in Whatcom County, but a statewide issue. Also, the BHASO has convened a workforce group that's more focused and centered on our region. I reached out to Joe Valentine, the director of that program, just to see if I could get an update or even be involved in that at this point. And so there are some, some statewide and some more local components that are going on about that. And so I can, bring information to this group and to the task force at large, in that regard.
Thanks, Perry. Michael Smith and then Arlene.
Yeah, a lot of the challenges that I see in the field, being a supervisor at a substance use and mental health inpatient treatment facility and being in the field for a decade in Seattle, Tacoma, it's pay, especially when you're dealing with serious mental illness. I mean, it's pay. I mean, you have people doing these jobs that make $19 an hour. I mean, it's tough work as it is, right? I mean, especially the serious mental illness side. So strategically and organizationally, putting a program together, that's pretty easy. I'm hearing a plethora of programs and ideas. And I mean, so all that's there. Obviously, funding is definitely needed, but it's just the amount of pay that people, feel that they need based on the economy. So that's kind of where my lens is.
Mike, I just want to follow up real quick before I go to Arlene. What should workers be paid per hour, in your opinion?
I would say at least 25 minimum. I mean, when you look at research that says, what the pay should be based on trying to provide housing for a 1-bedroom. I think the last research I saw said something about like $24.50 an hour just for a 1-bedroom. I mean, rent is really expensive out there. A lot of folks don't own homes. They're coming out of school. It's just too much to come to a place where you're dealing with people that are psychotic, substance-induced psychosis. I mean, $19 an hour, I can go sit somewhere and have somebody come see me one time, a day, or one-on-ones or something. But being out in the community, so trying to de-escalate somebody, trying to utilize every angle of intention to try to articulate to an individual, to get to an individual, that's a science, that's a craft, and people don't want to put in that work to develop that craft at $19 an hour. It's just not enough. You can get that bag of groceries at Hagen, let alone a 10-year master's degree. And you're out there, they want to give you $19 an hour. Go work at McDonald's, they're paying $17. I mean, Jiffy Lube is $18. I mean, it's tough. It's tough.
I hear that. Arlene, go ahead.
Well, I think Michael spoke for me really well. These are the primary points that I wanted to bring out. And, Michael and I are coming from the work itself, right? We're the ones who do this kind of work. I worked 10 years in crisis triage, which is now crisis stabilization. So I know a lot about Compass Health, and I know how they pay. And it's appalling. That's all, I could. And so what does that mean for us who are trying to get something done? And that means we need to lean on the providers, even though it's unpleasant to have to do things like that, but we need to do it because they're always paying attention to their profit margin. But I don't even agree with Michael on the minimum. I think the bare minimum would be $35, not $25. And I'm saying this partly because there's a big difference between counseling in a private practice office with people with normal neurotic issues, like somebody died or they got a divorce or they're having child problems, which is not the greatest stress of work. But I'm telling you that on the front lines where people are about to jump off of cliffs, so to speak, emotionally, the stress level of doing that work is very great. And the people who do it and do it well and with a good heart, it's almost like a calling. That's all I can say. It surprised me very much when I started to work at triage, and I liked the work. And I had never worked with that kind of population before in my life, but I had a feeling for it. And so I stayed and worked a long time. And that's where I learned what was missing in our mental health system, which is why I'm doing these committees all the time, because I just made up my mind that there's all these huge gaps in our system and we have to fill them. And I appreciate what Dan is saying, because civic and political action is slow and laborious and wastes a lot of time. I don't know that we could do something about that, but at least we could speak up. And that's what Dan is doing, and that's what I'm doing. And I want to say a word also for the proposal that Behavioral Health Committee has made to the county and to the county executive for ARPA funds for a 24/7 mental health emergency center. Because when you develop your team is going to need to have a place to take people. And this is one of the largest gaps in our mental health system, which is some place for people to go for immediate service, immediate care, no waiting, 24/7. We don't have it. We haven't had it. The only thing, significantly important, similar to that, would be hospital beds, which we don't have and haven't had for as long as I can remember. But this would be more important because it reaches, an emergency center will serve the whole range of ages, and no one will be denied care because of funding. So that's one of the things that we need to advocate for and be sure that we get that funded. Sorry for talking so long.
Thanks, Arlene. Chris and then Dean.
I appreciate it. I have to leave early and I apologize for that. So I would echo what some other people have said. And I think if you want to have a program that we can sustain, then all my friends and all the people that I know that are young, that are getting out of their master's degree, either go into community mental health and they pop right and they hang a shingle after they get their full license, which is 12 to 30 months somewhere, and they're hanging their own shingle. And the huge benefit for them is they can choose their clients. They can choose how many clients. They can choose if they want to get paneled with insurance. They can do private pay. There's all these different pieces of control and making it sustainable and healthy for them. If we want to have something like this where the work is just in and of itself is really taxing. I think if we wanted to have a crisis system that is in itself at crisis much of the time, you're going to have to look at whatever people are making in private practice and pay them, 20 to 25% more of that, knowing what Arlene said, that there is a calling to this. And if you want a system that's a crisis response system that's not constantly in crisis and turnover, you're gonna have to pay them more. I know the continuum of care is important. People are talking about those different services that we need, and some type of interdepartmental cross-discipline training where mental health people are aware of how to work with law enforcement and MCOT and all that stuff. I know that would come, but I just think I don't see any way around. Every day we're working at trying to get people in community mental health with our community partners, and they are having a heck of a time doing that. And that's not nearly as taxing as the work we're describing here. So I know that's the same for law enforcement as well, but I appreciate the time, and it's good to see you all. Thanks.
Thanks, Chris. Dean?
Yeah, so you asked, what can you as elected officials do to support getting this process moving more quickly? And I would say two things. One is whatever model we come back with, it's going to require collaboration across organizations and silos. And so to urge the leadership in those various sections of this whole array of organizations to put aside, control over the activities and figure out together how to collaborate across those organizational structures. That's going to be key, regardless of what model we come up with. The other is to be prepared when we come back with job descriptions and compensation proposals that accomplish what the mental health professionals you've heard from accomplish. That is to say that we can actually pay folks who what they need in order to come and take these jobs. And I am working with folks on looking at job descriptions and compensation pay rates to figure out what we're going to have to pay to make it work so we can recruit people.
Okay, I want to respond to that as an elected person. So money should never be a barrier in what we do. That it should just never be a barrier. $35 an hour to me seems reasonable for the type of work that is being performed. I don't know that I would want to go to a job where crisis is part of the job every single day. But for good compensation, I think that some people will do that. Will do that work. We have $5 million new dollars in Whatcom County, 3 in Bellingham and 2 in the county. That was part of 1590. 40% of those dollars need to go to mental health. I believe substance use is incorporated in that. I'd have to go back and look, and someone might know, Perry might know that one. Regardless, we have new dollars here in the community. We should be augmenting. The more I think about this, the more I think that this should be, it should be government. And I resist saying this, but I'm going to just say it. City of Bellingham is not a mental health provider. We're not a substance use disorder care provider, but maybe we need to be. Maybe we need to be, or at least that's housed here. City jobs they have pensions, they have good benefits, in vacation, things like that, and all the good things, medical. So maybe we should house this within the city. Maybe it should be housed at fire. My concern is that the workers need to have a supervisor that has background in behavioral health so that they feel supported when they have a grievance or a crisis. They can go to that supervisor and have that situation resolved and be heard. That's very important to me, that the workers are supported. So the more I think about it, that's my main concern about not having it at the city versus a provider. The problem with the providers is that they're for profit. I think Arlene mentioned the bottom line. That is absolutely true. If you're a company, you have to exist, and the way you do that is through profit. And maybe this isn't the right way to do it for providing these types of services. So what I want to do, Dean, is I want to support you in your work, and I want this committee to help support Dean and any other things that we do that are pursuant to helping people in crisis. That is one part of the issues that we face. GRACE is a different animal. It's a totally different program. So is LEAD. And ART is one of the spokes that we don't have in the wheel, and we need to get it going. So I will put a proposal in front of me. I will vote for it. If you need input on what I'm hearing from the community, I'm happy to provide it. If you need other supports, let me know. I'm totally here for you. Go ahead, Mike Parker.
Thanks, Dan. And inspiring to hear you say that cash shouldn't be an issue. And I think if we can actually do that and say, hey, this is important enough to make sure that our law enforcement has trained officers, to make sure that our alternative response teams are full and replete with quality credentialed people who will stay, then I say here. I just want to thank everybody who chimed in on that. That was very, very helpful. I had a feeling that pay was part of it. You're not supposed to answer part of your own question. I just wanted to bring up one other aspect that we see at Opportunity Council with people working in some of our supportive housing folks with serious mental illness. The other thing that happens is people are burning out. And so some of it is definitely cash. And I think that is an attraction issue for sure. It's also part of the retention issue. Dan, I really appreciate your comment that if you do locate behavioral health clinicians in a city department, let's say, that they're going to need adequate supervision. And I just want to touch on that very briefly, as I heard Michael Smith talk about some of the work and how taxing it is. And I would say the same, it goes for law enforcement that are doing that taxing work, but the ability to debrief and to make sure that when people finish their shift, that they're able to go home and be home with children and be able to make that shift and leave that work at work is extremely important. So I would just add to all those comments that really highlighted the need and put a spotlight on pay, that part of it also be the work environment, and that pay would also then include a system that has built-in support for those individuals who are working with serious mental illness. I remember we at the health department brought in a specialist to talk, and I remember the sheriff's deputies going and having a brief session with them after trying to get some tips for how do we work with our deputies who deal with traumatic stuff. It became very clear to me that it's not just our behavioral health clinicians who need this type of clinical support. It's absolutely critical. And I would just add then to those comments of, yes, we need to pay the clinicians, and yes, those clinicians need an excellent supervisor who's able to help them kind of deal with those particular issues.
Thanks, Mike. Anyone want to respond to that or add any comments or questions?
Just briefly, Dan, I would, some of the stuff that I've been seeing also has to do with looking at, what individuals do we have? And this is often true of where instead of going for somebody that maybe has a master's degree, as Mike Smith was talking about and so forth, we'll sort of step down a little bit and look at a bachelor's degree, or even, down into looking at peer support and so forth, which I think peer support's amazing. I think it's a fantastic idea, but I also feel cautious in regard to having individuals that do not have the experience, that do not have the education, put into situations and settings of, as we've been talking about, some of the most extreme settings. And so not that we're necessarily heading there, but just a balance and caution in terms of workforce in general is something we need to really pay attention to, because the quick answer can be, well, then let's find, bachelor's level people and we'll put them in there with some great supervision. And my experience is that doesn't tend to play out well. So I just offer that thought to add to what Mike had said.
Okay, Michael Smith.
Yeah, and I just want to clarify, when I'm talking about the pay, I'm talking about folks with associate's degrees and bachelor's degrees who come in these organizations. They can't even stay long enough to even get a master's degree, right? But I mean, they have to work to take care of themselves while they're going to school to get these master's degrees. So just walking in the door at different organizations, you're seeing a high turnover rate all the time. They just don't have enough. And then once you get in an organization, every year they inch you up, 50 cents, 70 cents. It's better to just leave and go to a new job that's paying a little more. You get a larger jump that way in your finances, just going to a different job. So my point at the 25 is folks with associates and bachelor's degrees need to be earning that. Just to clarify what Ann was saying, yeah, master's degree, we should definitely be talking about $35, $40 an hour to give supervision to individuals, but you can't even keep the folks with associates and bachelor's degrees because they're getting $16, $17, $19 at the most. Like, I mean, that to me is just utterly ridiculous. I don't control the purse, I don't control the funding, but I'm saying at least let's keep up with the inflation. Let's keep up with what our society needs for people to just not be homeless with a degree.
Well said. I agree, Michael. I mean, everything's more expensive now. I don't know if when the last time y'all have gone out to lunch, but you can't go to lunch for less than 15, 20 bucks, it seems like now. Yeah, everything's just more expensive. Housing is prohibitive in city of Bellingham for most people, unless you want to live in an apartment out in Cordata, which I'm not slamming that. It's just that that's reality for a lot of folks. And I don't know. I think these problems don't seem insurmountable to me. They just seem a matter of logistics and then figuring out where we come up with the money. And we have new money, so let's just use that then for what we're identifying here. And maybe I'm a little bit too close to the behavioral health stuff because of the work that we do in this committee. But I mean, law enforcement reports to us that, upwards of 80% or more of their calls have some kind of behavioral health component. So this is not, and the anxiety that's produced by the pandemic, I think people's limbic systems and central nervous systems are out of whack. And so I think we're just going to see more of this. And maybe it's not going to come out on the criminogenic side, but it's going to come out. And so I think we just need to have some kind of, we need to have a response, and we need to have it now, basically is what I'm saying. So, and I know we're kind of going round and round on this one. I want to make sure it gets the time that it deserves, but does anyone else have any other thoughts or questions on this? Okay.
Dan, I don't. I would just like to bring up, in the interest of time, this has been an extremely good conversation. It obviously took more, I think, than we planned as co-chairs. And that I would just bring up to you, since you're chairing the meeting today, that the review of priority items would be something that we can move to a future meeting. And then just a quick mention that thinking about what we want to do with the remainder of our about 18 minutes or so, I would think that the identifying key messages for a consultant would be pretty crucial, but I'll defer to you on that.
Mike, I think you're fine. I think that's a good call. I'm toggling in between our call here and the agenda. Can you, okay, so it's item number 3 is what you're saying, task force communications? Is that what you're at?
It seemed to be kind of a matter of higher import maybe than some of the other ones. And we might be able to get some good input if people feel like we've kind of moved on from the ART discussion.
Jill here. If this isn't something that needs to be decided right away, so I think although it's an important decision, it's not something that needs to be done right away. We're likely not going to get a consultant on board for some time, so we can for sure put this off to a future meeting.
Okay, Mike Parker, what do you?
Thanks, Jill.
Mike, what do you want to do here?
That's really handy to know. I didn't know that we had that flexibility. Then, I'm open to what the group thinks. I do think that we've heard from a couple of different presentations, and I think finding out if there's action or if we need to do further work from them seems to be at least, it's close in timing, right? We just had a presentation from Dr. Harris. Chris Cochran gave us a presentation. I think it was last meeting, and then we've just had a presentation from Doug. And I think one of the reason Dan and I put this on the list, just for the good of the order for all of the subcommittee members, we wanted to find out from you all, as you've had some of this information brought up to you, as it sits, are there action steps that we should be taking or could be taking, or that might be beneficial to take based on information that we've gotten? So Dan, I might argue for that one, for just a debrief and run down quickly on those presentations, and then see what the behavioral health committee members see if there's any next steps that they would like us to take as a group.
Okay, do you want to just get us started? I'm going to grab some more coffee real quick, like I need any more, but
Sure. Well, with that lead in, hopefully that was enough of a tee off. Again, I want to thank everybody for that discussion. I think the numbers actually help. So when folks were venturing a number that we need to pay people an hourly wage, I think it's those kind of conversations that can help shape and move things. Other than the notes and the fact that we're having a public meeting, I think it's important that we advocate in whatever spaces we're in and can be in, and if we're at a seat of at a funding table, because we want these initiatives to happen. And in order for the committee recommendations to come forth, it's going to need some force and will. So thank you all for one, for your opinions, but two, I think the numbers really help and give us something to push forth on. I guess the first one that I would bring up is just because we just heard it today, and what we heard from Under Sheriff Chadwick about impact, and we're hearing that Whatcom County is more than ready to go with an impact type program. And so I guess I would ask the group, now that you've heard from that, how does this fit in terms of your priorities for the behavioral health subcommittee to get behind? And is there something, I guess this question would be directly to Doug, but to others too, is there some action that we might take that might further that? Doug, maybe I'll start with you since you made that presentation for us, which was great. Is there some action or some support that we might be able to do to help further that?
Yeah, like I said, I don't know where it sits as far as the funding that Ann Deacon talked about before she retired, but I'd like to find out what the status of that is, if we can actually post for those positions. And I think going forward, Dan asked, what can I do as a council member? In your discussions, I think part of the problem is we, a lot of discussions in a lot of different jurisdictions. I watched the mayor debate down in Seattle and basically taking money from law enforcement and shifting it to mental health. It's not a or, it's an and that needs to be part of the discussion is law enforcement and behavioral health providers. It's a symbiotic relationship. They need each other. If we're talking about reducing funds for law enforcement, we don't need to reduce law enforcement funds. We need to increase the funds for the behavioral health community and mental health and have them working, efficiently together to address the problem. But when you talk about taking from one and giving to the other, what you're seeing is the law enforcement doesn't want to participate because you're telling them you don't want them to participate in that. And maybe Dan, that's I don't know as far as Bellingham, but maybe that's part of it is. And then from we're trying to recruit people into the behavioral health field as Michael talked about, and a lot of them have safety concerns about if this is the program that we're moving to and law enforcement isn't going to be part of that, where does that leave me? And if I'm not being paid well and I'm putting myself in a risky position, then maybe that causes people some hesitation. So I think just in those conversations when we're talking about funding and increasing capacity, I think just in the back of your mind, just it's a law enforcement and behavioral health. We shouldn't rob from Peter to pay Paul, because that's not productive. Like I said, it's a symbiotic relationship. They need each other. The mental health providers need that safety when they're out in the field and to know that that's going to be there. And law enforcement needs to know that they can call on behavioral health clinicians and they're going to respond, hopefully out in the field, and it's prompt and it's efficient, and we can provide people to the services that they need immediately and where they live, as opposed to having to transport them somewhere else or having a delayed response for that. So that would be my only suggestion going forward.
Perry?
I agree 100% on what Doug was saying. Just real concerns about the thought process of it's one or the other. It most certainly isn't, and funding super important. And I cheated during our meeting. I texted Ms. Deacon and asked her specifically about that. I had my suspicions that the funding that she was making reference to was actually in connection to the Behavioral Health Administrative Services Organization. The dollars that they receive are predominantly focused towards crisis services now. That changed, but that is what their primary focus is. And I know that there are additional dollars that have come in. And so she was making reference to that in terms of funding. And there had been some discussions of an impact type model as well. And so I will take responsibility to get more detail about that from Joe Valentine, and then bring it back to this group for our next meeting. So
That'd be great. Thanks, Perry. Chief Tanksley?
Yes, I certainly second what the undersheriff said with regard to trying to get the funding for the sheriff's department. And certainly if we could get at least one department up and going consistently, and then perhaps maybe other departments could take any lessons learned and things to change from like the sheriff's office, I think that would be great, but we need to get it rolling.
All right, any other discussion on this particular topic? If not, just to remind folks, we also had Dr. Harris come present. That was a lot about data. And so if there was anything on that one, and then Chris Cochran's presentation was on kind of youth interventions in the school districts. And we heard from Chris today, reaching out and looking to see if there's a way to work even closer with Sheriff's Department and other law enforcement. Are there any other comments on those, either those presentations or ideas that we should take forward?
Just a data point that the school resource officer program will be no longer in Bellingham schools. The BPD is basically going to be doing patrol and detective investigation work, and that's it. So that everything else is going away. So just so folks understand that with the schools, that resource officer will not be in play anymore.
All right, I wanted to give it at least that awkward Zoom pause just to make sure that everybody had a minute to go through that. We have a lot of follow-up on some future items, Perry. We do appreciate you getting some of the data and bringing that back. I certainly, am galvanized even more to try to further. I think the call from this committee that we need to get serious in this county about paying our behavioral health clinicians. We need to get serious about getting our reform programs, our additive programs off the ground. We also need to get serious about working and partnering better with law enforcement so that there's not an us and them. I believe fully in what Under Sheriff Chagwood said, and I think that's always been the case, and that's one of the things that was challenging, I think, in the meeting with Representative Shoemake and Rammel, is that we felt like we didn't have enough time to stand up the behavioral health crisis response. We didn't feel like we had enough time to create that system and that level of support before we start having things that are affecting the field of practice, right? And I think the laws came in and affected the field of practice. I think we're seeing those effects, and we're going to have to get responsive and to get on it. So with that, we have just a few minutes left, and Dan, if that's all right with you, I'll just give a brief update on the Government Alliance on Race and Equity. As this group probably knows, Whatcom County has decided to join that. Whether that has actually officially happened yet, I'm not sure. I don't know if anybody on this call knows. I don't believe we have officially joined, but I know the decision was made to do so. One of the reasons I bring that up is, one, for celebration. I think it's an extremely important step, and I think as people interested and genuinely passionate and caring about racial equity and issues of racial equity in our community, I also see that we need support. And I really just want to commend all the folks who made that decision to join the Government Alliance in Race and Equity. It is not something that's going to fix all of our issues. We still have to do the heavy lifting. We still have to do the work. And as Stephen Gockley told you, he was on a membership thing. We're far ahead in some areas, right? So we're obviously, it's going to be a mixed thing. But I just want to state that as we think about all this, and this very committee that seeks to bring behavioral health services to people and not incarceration, it is very much centered on racial equity. And I'm hopeful. I think also that the county will be seeking to have lead folks in each of the standing committees, especially the Incarceration Prevention Reduction Task Force. I think will be a key to have a representative. It's also my understanding that they plan to have identified representatives in each of the major departments. So obviously the health department or housing human services, we should expect to see them. I think assessor's office, you name it. There's look for that. The reason I bring that up is I was approached. I am happy to do so. Again, as I have told you before, I may not be the best person to carry that message. I'm happy to carry it until such a time. I just want to make that broadly known that that there may be an opportunity for input into the overall county response to our discussions about racial equity and moving the needle on racial equity. So with that, I will go ahead and stop on that point and turn it back to Dan. Dan, I'm going to hand you back the gavel.
Okay. I'm wondering, Undersheriff, would it be helpful to have a recommendation from this committee to institute a impact-like program for the county? Would that be helpful or not?
I certainly think any support we can get for that program, I think, like I said, as far as the county goes, I think it's a better model than an unarmed response, and I certainly understand that. My concern all along has been safety and providing the services where people are, as opposed to having to bring them all the way into Bellingham. So I would certainly accept that support from this committee.
Okay, well, I'm going to go ahead and make a motion to support the development of an impact-like program and make that recommendation to the broader Incarceration Prevention and Reduction Task Force.
I'd gladly make a second.
Okay. There's a motion by the chair on the table and seconded by the co-chair. Any discussion? All right, seeing none, all those in favor signify by saying aye.
Aye.
Opposed? Abstentions? Okay, motion carries. Jill Nixon, do you have that? Is that enough for you?
Yes, I have that. Thank you.
Okay, so we'll make that recommendation, and we're still a little ways out. We just had our main task force meeting yesterday, so it's going to be a month before that goes to them. But I do want to plant that flag, so to speak, because I think that it's an important program, and I understand the co-responder model is probably a much better model for the county than necessarily for the city. Pardon me. Although I do support, I just want to state this, that I did support having an officer along as a co-responder for the pilot phase of the Bellingham model, just so we could try to expand the call types. Basically, that was really the main motivating factor. But anyway, Stephen Gockley, go ahead.
Thanks, Dan. I will reluctantly admit that today's presentation by Under Sheriff Chadwick was the first I knew of the impact program. I found it pretty compelling, and I think it fits really well with the work that Dean and Perry are doing and other players in this area. However, the steering committee and the whole task force probably are as ignorant about the impact program and the reasons that led us to make this decision as I was at 9 o'clock this morning. So as we try to move this forward, I think it ought to lead with some education and some integration into other conversations that have been developing to this point. And I just urge us to do a thoughtful process for bringing it to a decision point in other bodies.
Ever the thoughtful attorney, Mr. Gockley. Thank you. Dean White, go ahead.
Yeah, I guess I just want to make sure that your motion really has to do with the concepts of the program and not specifically an endorsement to contract with a particular organization to do that work. Because I think, as Doug noted in the presentation, there are elements already in place. How do we emulate the model, but within the framework of things we already have in place?
Yeah, I hear you. What I would say is the very similar path that when the Public Safety, Health, Safety, and Justice Committee made the recommendation to the council. The motion was more of let's get the concept moving forward. Let's build out what that looks like. And then as far as funding and further implementation, that's more of an administrative component. So I'm in agreement, Dean. I get it. I get it. And Stephen, I think you're right too. I think perhaps it might benefit the broader task force, or I don't know, steering then task force to just to have that presentation, Doug, that you did here today, and the slides that are in your packet, in our packet today, presented to the broader task force so they have something to digest before they make a decision.
I'd be happy to do that.
Okay. All right. Jill, can we make sure that that the broader task force gets the packet materials?
Yes.
Okay. Okay, we're almost at time here. Anything else for the good of the order today?
Dan, I'd just say it might be wise to start with steering committee, build the momentum for Doug's presentation.
Okay. Yeah, okay, good call. I think in terms of process, that's probably the best way to go. So steering meets in between now and the next task force meeting. Is that correct, Jill?
Yes, that's correct.
Okay, then let's go ahead and get that as an agenda item, or I'm going to propose that as an agenda item for steering, and then we can go to the main task force. Mike Parker.
Thanks for calling. This is just a point of clarification. The comment was made earlier that Compass was for profit. Compass is actually a non-for-profit corporation, as is most of our behavioral health providing organizations. It doesn't mean that cost effectiveness is not important to them. I'm sure it is. And there's a lot of areas of that, and people that are smarter than me know that, but Medicaid reimbursement rates among one of them. There are a host of issues, but I just wanted to clarify that the Compass is a nonprofit, as is most of the behavioral health providers. Thanks.
Okay, thanks for the clarification. At this time, we'll go to public comment. Jill, do we have anybody that wants to speak?
Yes, we have 2 attendees. Mark Gardner would like to speak. Go ahead, Mark. You should be able to speak.
Hello, this is Mark Gardner. I've been attending these meetings since their inception. I guess, what is it, 5 or 6 years ago? And this is the best conversation I've heard really in all that time. I think that it strikes me that the fact that the pandemic, and it just seems like many things in society are literally disintegrating around us, is forcing our minds to really grapple with larger things. And just as I'll try to be real quick here, but I've been looking at the sort of deep picture of these structural issues that we're facing. And we essentially have things that for like 50, 60, 70 years, we've been dismantling a proper system. I mean, it started with our behavioral health system. We started dismantling it, 70 years ago, and then we forgot to build a new one. And then with housing, we put all these structural impediments to actual creation of affordable housing. And when it comes to actually creating government capacity, there was a paradigm shift in the 90s that said everything had to be done by the private sector, either for-profit or nonprofit. And if they can't provide it, then it doesn't get done. And I think that the conversation today is moving towards, if the private sector can't do it, government has to have that responsibility, and it cannot do everything, because we know the federal and state systems are making it really hard for localities to do what they have to do. But if it's a matter of just shifting the paradigm towards saying if government has to do it, then they have to take that responsibility. And if it's more efficient, better to work with partners in that, then we do it. If not, then we don't. And I think that's kind of it was a fundamental error that we made in the 90s to make that assumption, and then government becomes kind of a passive entity waiting for things to fall into place. So I really appreciate the conversation that sometimes we just have to kind of jump on it and make things happen and decide what capacity we need and find a way to do it. And then, so I really appreciate the difficult conversation, but it was inspiring. So thanks a lot.
Thank you, Mark. If you, we have one other attendee. If you would like to speak to the committee, please virtually raise your hand now. No hands are raised. If I could get Mike Parker and Perry Mowry to stay after the meeting if you have a moment. That would be great. Thank you.
Okay. All right. Thanks, everyone. Appreciate the conversation today. Have a good rest of your day. We are adjourned.